Thank you all for joining us this evening. My name is Susan Getz. I'm one of the co-chairs of the Vassar Center Parents Leadership Community, along with Shari Potter, Raquel Haas, and Helene Soren. I'm also a member of the Vassar Center Advisory Board. We launched the Parents Leadership Community as a supportive forum for parents of children who have or may be faced with a BRCA genetic mutation. In addition, we serve as a resource to stay informed about the latest advances in BRCA research and care. For the young adults here tonight, you should also know that Vassar Center has the Young Leadership Council, which is a group of 168 BRCA-affected men and women across 29 states who come together to also stay informed about the latest advances in BRCA-related cancer. Both of the PLC and the YLC are overseen by the wonderful Carolyn Brown, who has helped organize this tonight from Penn, and find her in the red jacket if you want some more information. Having had breast cancer myself at 32, I can only wish that these two groups existed back then as a means of support for my parents and me. Tonight's discussion will focus on supporting your adult children while navigating the realities of BRCA mutation in your family. The opinions and experience shared tonight are the panelists' own and do not represent those of the Vassar Center, its Parents Leadership Community, or Penn Medicine, and you should consult with your healthcare team should you have any questions about the specifics of your health and medical plan. Thank you to the team at Peoplehood for allowing us to use this beautiful space for the event. Our moderator tonight, before I introduce our moderator tonight, journalist Jill Werman-Harris, I'll tell you that Jill has a background in bioethics and has written for medical journals, including the New York Times, the Jewish Forward, among others, and she is going to lead our discussion tonight.
Hi, everyone. I'm really happy to be here to talk about BRCA genetic mutations, and it's a topic about which there's a lot to say. So I'm going to jump right in here with this truth. News from the future can be really disorienting. And for the parents of adult children, many of whom have their own BRCA stories, facing this predicament, or even the possibility of this predicament, can be extra tough because it involves the very primal instinct to protect your child. And it's complicated, right? Because that child is actually an adult with their very own, very personal ideas about what they want for their body and for their future. So it is from this perspective that I'd like to introduce four very insightful clinicians, all of whom have a lot of experience with the complexity and vulnerability of the BRCA experience. On my left is Dana Farengo-Clark. She is a senior genetic counselor at the Vassar Center for BRCA. Dr. Samantha Zuckerman is a breast radiologist at Penn Medicine. Dr. Isabel Bloomberg is a New York City-based OBGYN, and Dr. Allison Werner-Lin is a clinical social worker who spends a lot of time thinking about the intersection of genomic discovery and family life. Now, we also have a bonus expert here tonight in the audience. There is the unstoppable executive director of the Vassar Center for BRCA. Now, Susan is usually up here with me, but I am publicly reserving the right to ask you a question or two if it comes up, notwithstanding where she is sitting this evening. And speaking about questions, there may be an index card or some piece of paper on your seats. And if you have a question tonight for the panelists, and I hope you do, please write it down and pass it along to Carolyn in the red jacket. Yeah. So thank you all so much for being here tonight. So let's begin with Dana Farengo-Clark. Now, when we think about genetic counselors, we understand that their expertise is in genetics, but we often forget that their expertise is also in counseling, which is so essential to those with genetic predisposition. So Dana, can you start us out with some basics? What are these genes? What do they mean for mutation carriers, both BRCA1 and BRCA2, in terms of risk?
Sure, and welcome everyone, and thank you for inviting me here. So you're no stranger to BRCA1 and 2, but to go over basic risks, and I just want to say, because we're talking to a wide, diverse audience of people of all ages, that I think it's really important if and when you find out you have a BRCA1 or 2 mutation, that you ask the person that you're talking to provide age-related risks, right? So to tell you probably know this. The risk to develop breast cancer is, depending on what you read, 40 to 80%. The risk to develop ovarian cancer, 10 to 20% in BRCA2, 30 to 40% with BRCA1. But I think when you're talking to a 25-year-old, to tell them what their risk to develop a cancer at age 80 is becomes a little, overwhelming, to say the least. So I think it's very important when we give people information and when people are seeking information that you get it in the context of what's my risk in maybe the next 5 to 10 years, because that's when you're going to be making decisions. So again, overall risks are what you see, but ask for more than that, and a provider should be able to tell you those risks. With both BRCA1 and 2, there's a slightly elevated risk of pancreatic cancer. Again, for our young people, that's something that I always say to young people, yes, it's present, you will read about it, but that doesn't impact you now, so let's not talk about it now. There's enough to talk about. Let's kick that can down the road until maybe 50. We'll have more data, we'll have more, concrete information for you, and it's not pertinent today. So let's not worry about what's not pertinent today. The risk of melanoma, I kind of say to people, that's the easy one. Go see a dermatologist once a year, which everybody should do. It's about 3 to 5%. So once you pass the ovarian hump, it does get a little less. For our male carriers, there is a risk of male breast cancer. As we all know, male breast cancer in the general population is very, very rare. Less than 1% of men will develop breast cancer. In a BRCA positive man, it's elevated about 5 to 10% for a BRCA2 positive man, up to about 5% for a BRCA1 positive man. Breast exams are usually done starting around age 35. So we do, and when we're talking to our boys, this is important not just for reproductive risk, it's important for them. We want to make sure they're being taken care of too. And then the risk of prostate cancer. Certainly we know as they get older, every man gets the risk of prostate cancer goes up as we get older. It's usually a disease of older guys, 60s, 70s, 80s, and usually that's kind of a slow-growing, more benign-looking cancer. In our BRCA positive men, especially BRCA2s, the risk can straddle the general population risk about 15 to 25%. But these guys can develop it younger, it can be more aggressive. So we do start screening them around 10 years earlier than we do in the general population. Again, I think these numbers, when you're talking to a 25-year-old, yes, this is something you will need to act on later down the road. But for now, let's just sort of take in that this is what's going on for you. But we'll take care of you. We'll see you once a year, and we'll sort of deal with the risks as they pop up. So I think throwing every risk out at once is overwhelming and challenging. So try to, piecemeal it and ask questions and in an age-appropriate way.
Yeah, much of the decision-making around testing is about timing. And so when you told me that some people come to you, they're carriers, and their children are turning 18, and they want to know what they can do next. Can you talk to us about this concept that you explained to me about called chunking, and what you do about those real-world issues that come into play?
Yeah, so chunking I made up. That's not a technical term. I'll throw that out there. I don't think it's any... If you Google chunking, I don't think this is what you'll come up with. But this, I don't know what you would come up with, by the way. So this is sort of how I think about it. I think about when people are being tested, parents have every good intention in the world, and I know I have a 15-year-old daughter. We want what's best for our children. So we think decisions that we are making may be the right ones, but I think we have to think about our kids and that they clearly want to make their own decisions too. So when a child turns 18, that's when they can be tested, but I think we all need to then start to have the conversation, when should they be tested? So we've always sort of thought about, so this chunking is, I think about 18 to 25, especially for females, right? 25 is when we are going to start medical intervention, as you guys will hear about. So that's when we're going to start doing breast imaging for breast cancer. So prior to the age of 25, why does someone want to know? I've had girls on their 18th birthday walk in and say, I just need to know. I've had moms who've said, I just want her to be negative and then we'll be done with it. Yeah, I can't guarantee that, and neither can you. So that's an issue if you just want to get it out of the way because she's going to be negative. It's 50-50. So I think my thought of chunking is that from 18 to 25, this is the time to think about, insurance, procuring insurance before a child starts to be tested. 18 to 21, for those of us who have gone through college, it's tumultuous anyway in terms of life. So is throwing a diagnosis of a BRCA mutation going to help that child? Some of them, the anxiety of not knowing is far worse than knowing, but you also have to discuss that them anywhere from 18 before you hit 25, you're just going to know this, and you're just going to sort of be sitting with this information. You're not necessarily going to be able to actively, quote unquote, do anything, right? You may get a breast exam. You can get a breast exam regardless with your gynecologist. So I really try to think about before 25 as one group of but you can't really act on it. After 25, I think you think about the practical things. Are they getting their first job? Are they going to more school? Again, procuring insurance and making sure that the youth getting the testing, the young adult getting the testing knows that there's they have to talk to someone about all the practical things. I had a really astute patient who came to me. She was 21. She was about to graduate college. And I said, we talked about all of those things. And I said, if you're positive for 4 years, she said, here's the deal. I have this great job offer. It's a job I really, really, really want, but it has the worst insurance that one could ever get. They will pay for nothing. Then there's this kind of ick job. I don't really want it, but it has solid insurance. It's fantastic from that perspective. I want to know my status because I want to know if I take the great job with the bad benefits or the bad job with the good benefits, because I know I'm going to need them if I'm positive. That's a kid that's thought about this. Go for it. You got my blessing, and we'll do it. So I think there's every age, there's questions to ask, and what's the motivation for doing it, whatever time in life they're trying to do it.
Yeah, things you wouldn't normally think about.
Correct.
Allison, I'm going to bring you in here to talk about the uncertainty of testing. So on the one hand, there's this perspective of the power of knowledge. And on the other hand, there's this perspective of what they call in bioethics, the burden of knowledge. How can people get to a place of clarity in figuring out, do they want to know?
Yeah, thank you. It's a great question. I was scribbling notes madly down as you were talking, things that I wanted to bring up. I think from my perspective as a clinician and as a researcher, one of the most important pieces is to recognize that these are processes. These are not one point in time. And so when we have a process, a long drawn-out process, a lifelong process with BRCA, a relationship with BRCA in our bodies, we can think about in chunks, right? The different phases of what happens when and what has to happen when. And one of the things that I talk about with the folks that I work with is distinguishing urgent decisions from important decisions. Some decisions need to be made right away. Some decisions like life insurance, right? It's not something your peers are going to be thinking about, but that's okay. That's okay. There are people in your world who will help you make these choices and navigate these spaces. Important decisions are ones that might take time, and that's okay too. They don't need to be made today or tomorrow. And so much is happening during this developmental period, during young adulthood, that balancing this, balancing BRCA, balancing testing, balancing risk management, balancing our very loving and well-intentioned parents, and I say that in this room with my young adult child in the room, is complicated. It's really complicated. And one of the pieces, Dana, that you mentioned is getting age-related risk markers. So one of the things I want to say about that is that many of you in the room who are younger might have the same genetic counselor or physicians as your parents, right? So the information that your parents may have gotten about age-related risk is going to be very different than the information you may be getting. And so having a conversation with your doctors about what your age-related risk is critical to help facilitate not just your risk management, but how to talk with your family about what's good for you, about what kind of timelines make sense for you, about when to approach those decisions. And I also wanted to say it's great to say, let's put this on the back burner. If anybody in here can figure out how to do that, let me know. Right? Let me know. Because it's like, oh, don't worry. Oh, okay. Well, I was going to, but now I won't since you said that, right? So one of the overarching pieces, and this comes back to the uncertainty, Jill, and this is so critical. When that 18-year-old comes in and says, I'm so anxious, I need to know, that anxiety is about uncertainty, not knowing what's coming down the pike or when or how good or how bad or how mixed, how complicated. That's a part of life. That is part of the human experience. So we can test that 18-year-old, and maybe they're negative, but there's going to be another uncertainty down the road, or maybe they're positive, and now there's a different set of uncertainties that they're working with. So I would advocate, in addition to that very close relationship with your medical care team, figuring out what ways you can work with uncertainty yourself, and what skills you have to cope with uncertainty, because that's going to be here no matter what kinds of answers or results you get along the way.
You know, there's this very unique terror that comes into play when it's your children, right? Only parents understand that. So how can parents help their grown children make the best decisions for themselves, but also kind of acknowledge and manage their own fears, their own emotions, and their concerns?
Yeah, it's such a great question. I think at this point in the life cycle, it's a critical question because we have young adults who are, right, we know that the frontal lobe, our brain, is not fully developed until, right, mid-20s. For some of us, it takes longer. For some of it never happens. But the idea that young adults are reaching out into the world, right, and trying to figure out who they're going to be, what they're going to take of what their parents have shown them about the world, or their caregivers, their loved ones, their partners, and then move in the world in their own ways. And at the same time, parents, and I say this from a personal perspective, but also clinically and empirically, we still very much look at young youth, those of you who are in this age group, as our kids. We call you our kids. And that automatically puts you in this bucket of needing to be cared for. So this is another piece that's a process, figuring out how to talk as adults, even parent and child, figuring out how to embrace the part of these discussions that is about love and fear, and even when those are sometimes experienced as pressure and coercion. Because what is underneath that is love and care and concern and investment and hope. And if we can put those things on the table, we can have much more clear conversations.
Sounds like that might be good for the world at large, politically.
I think so,
countries
but I
can think
can't
about.
sell it. So,
Dana, for many people, the rapid evolution of technology with the increasing number of panels and tests and mutations feels really confusing. Why is it like that? And what do you do about it? How do you counsel patients?
Yeah, it's a good question. So I sort of equate genetic testing today to just the wild, wild west of, you know, there's so many different tests. And I think if you go to a center, they'll tell you this is absolutely the right test. And then you go to a different place and they tell you, what? You were only tested for 40 genes? We test for 87 and ours is better. So I don't know that there is, the other problem is there's no consensus guideline, right? You can't open a book or a journal and say, oh, that's what I'm supposed to order because this person has X. I had a patient who said, just test me for the breast cancer genes. That's all I want to know about. No, they all have passengers, right? They all have partners. They all have other cancers. So I think, you know, the right answer is there is no right answer. So I think you have to go, if there's a known mutation in the family, I also think that there's a lot of pressure when you go see someone that they'll say, yes, we know your family history is thoroughly explained by this BRCA1 mutation, but you know what? We could offer you 70 other genes. Why not? It's no cost difference. There's no, you know, turnaround time's the same. So I have a frank conversation with patients of, we know what's going on in your family. If that's what you want to know about, we are going to just order that gene. And I think that's almost considered blasphemy at this point. I don't know. But I'm still okay with it. The family history is consistent with a BRCA1 mutation. Let's know that for now. Then let's say you come back to me in 5 years and say, you know what? 7 people in my dad's family now have colon cancer. We can always do it at that point. Again, this idea of like so much information and giving it all at once. Is it necessary? Is it needed? So I think the question, everybody's going to offer you something different, but I think you have to at least tell the patient, this is what's going on. This is what's really important now to be tested for. We can always do more later. Or they say, I just want to know everything, just get it done. And then you haven't, you know, sort of, Allison, what you were alluding to, why do you want to know all that? Are you worried about something else? Is there something else going on? And then kind of walk through the patient, here's the reasons why, you know, doing 40 genes may not be the best answer in the world, and coming to a place of agreement, understanding, as much, you know, sort of acceptance as you can that this really is the right time and information for me.
And can I pick up on that?
Please.
You know, culturally, we are a more is better society in the U.S., right? That's how we move through the world, and that's what we are in large parts to the world, is a more is better. And in this situation, we don't need that in the same way and at the same time. But we are, when you offer one test, right, one gene test as opposed to the 58 or 110 or 12,987, people, you might feel gypped, like you're not getting all of the things you could.
There's a genetic FOMO, right?
Yes,
Like I missed something, and you'll always miss something, right? I think it's us that we're scared of it.
And I want the best for my kids, so I'm going to get them everything.
Yeah.
Right? So the challenge there, though, is then what are you going to do with the information?
Right.
So we talk about actionability, the ability to take it. Information really is power when we can do something. So is having that information in this moment going to change your behavior? If you're going to go for your regular screenings without having a test result because you have a family history, power to you. If you want to make a decision about surgery, we're going to hear about this on the panel. That information is critical in that moment. That becomes urgent, right? So thinking about how you're going to use the information is important. And a lot of research, and this is, I think, a challenge that I've been trying to move away from in my own work, is looking at decisions around testing, around surgery as yes or no. A year out, have they done it? Well, why? Why have people done what they've done a year after testing, or 2 years, or 10 years? And then we get into the nitty-gritty of life. Life is messy. We are, as a species, we are really bad at predicting how we're going to react to situations. I don't know if any of you have noticed this. So we need time to sit with information, and parents as well need time to sit with their children's information and figure out how they experience and understand themselves and their relationship to their genetic mutation status before sitting down really with your kids and helping them wade through that information themselves together.
That's excellent advice. Dana, you've done research on Cascade testing. I don't know that a lot of people know what that is. Can you explain it, and whether or not you see that same tension that Allison is talking about in Cascade families?
So Cascade testing is just the, sort of idea that you're testing other family members, that it's a waterfall, right? Some people call it waterfall testing, that someone finds out they have this mutation, and then they have to, disseminate information and tell people, their siblings, their children, their cousins that they haven't talked to in 10 years, that they feel this, now it's their, I don't ever want to use the word burden, right? This is information, it's powerful, I think it saves lives, so I don't view it as a burden, but it can feel like that when you're the one that found out, and now you have to tell all of these people. So I think as a general, sort of field, we don't see the Cascade testing rates as high. We would think that you give this person the information, they go out and do it. Not true. Why? I think some people don't know how to tell their family, right? And it is so hard. You pick up the phone once, you tell someone this whole long story. I have this BRCA mutation. You may be disclosing a cancer that they didn't know you had. You may have to talk about an aunt that died of ovarian cancer that they didn't even know. So you go through this whole long thing, you hang up the phone and you go, I can't do that again. Yeah. The thought of presenting this to your children, people don't know how to do it. And I say to people, the one thing you have to realize, if you do this test, and if there's a high likelihood that they're going to come back positive, I really do spend some time that you are now the gatekeeper of this information. We've seen too many families that they don't disseminate the information, and then you get a member from some other branch that you then put together, oh my God, this is this person's cousin, and they didn't know there was this BRCA mutation in the family. So I think it's a really important, it's really important, obviously, that families are in communication, but reality is that they're not always. So we need to do better as a profession, I think, at finding ways to help. Now, privacy laws get in the way of a lot of, we can't just reach out and call your brother and tell him this. He may hang up on us, he may sue us, who knows. So I think the idea of Cascade testing is everybody tells everybody and everybody comes in and it works. And I don't know that that's necessarily, families are super messy and we all know that.
You think?
Yeah, I do. Yeah. So I think, I think we have to find maybe new ways to do it. We are looking at them at Penn, and there's lots of projects looking at how to tell family members and what's the best way. But I think we have a lot of work to do in the Cascade arena.
And a lot of emotions come up because some people don't want to know.
Yes.
Right? And
Yes.
then you get a lot of resentment and a lot of complication.
Absolutely, and I was talking about this with someone. You have a patient who says, "I didn't want to know this, and now you've told me, and now I have to make a decision." Right? You've just now really presented something to me that, had you asked me, "Do you want to know really important information?" and I said no, then you stop there. But I think people feel like I have a duty to inform them, and they take that very seriously. Right. But the family may just not. There's members of our family that are ostriches, and they don't want to know the information. So I think we have to be respectful of that too, but it's hard.
Very hard. Thank you so much.
Of course.
Let's move on to what happens after testing and talk to Dr. Samantha Zuckerman about breast surveillance. Tell us about screening and what women need to be doing.
So in general, for a patient that is a BRCA mutation carrier, we have them start screening around age 25 with MRI. And we would do MRI every year. And then we add on mammography at age 30. And then what we'd like to do is have them come in 6-month increments. So they're getting one test once a year, but we're seeing them every 6 months with a different test. So that way we're seeing them more frequently. And then in between those tests, that's when we would want them getting physical exams with their oncologist or their GYN. So that way a doctor is always interfacing with them, seeing them, and we're screening them at these very short increments.
Does it make a difference if you're BRCA, if you have a mutation or you're just high risk or you haven't tested yet? Is that the same protocol?
Yeah. So there's certain criteria for people that we consider high risk. A known BRCA mutation carrier is always considered high risk and would fall under that category. But also people who have a first-degree relative that's a known BRCA carrier, but they themselves have not been tested, they would fall into that category. So when you think about your adult children, if they have not yet been tested, if you or your spouse has this BRCA mutation, your child would also be eligible for this enhanced screening, even if they didn't have the test themselves. And then there's other subsets of populations that are considered high risk for breast cancer. And those are patients who, through a combination of things, have had high-risk pathology on biopsy, someone who's had Hodgkin's lymphoma at a young age, prior to age 30, and has received chest wall radiation. Those are different groups of people that are also at increased risk for breast cancer. So we follow a similar protocol for those group of people as well, with starting MRI at an earlier age and then layering on mammography once they're 30.
So we've talked a lot already about this idea of lifetime risk. And for carriers, I think a lot of people do forget that, which is why it's so important when you have a 25-year-old who comes in. So diagnoses can come in early in one's life, it can come in later, or it can come in not at all in some cases. So with MRI screening, that starts at 25. And starting so young, there has been some chatter and some concern about the chemical contrast agent that's used. It's called gadolinium. And it's being given, as you say, annually, year after year, decade after decade. If a young woman is starting at the age of 25 and she's having it for 20, 30 years. Can you explain why radiology requires it and whether or not the worry is warranted?
Absolutely. So MRI and the use of gadolinium allows us to see vascular enhancement, and that's often the earliest stage of breast cancer. It's a physiologic marker versus when we're looking at mammography or we're looking at ultrasound. In those modalities, we're looking for something anatomic. So at that point, it's a larger mass or it's calcifications on a mammogram. MRI is going to allow us to pick up breast cancer at its earliest possible stage. It's also not inhibited by breast density, which most young women have. Most young, thin women, premenopausal, the majority of them have dense breasts. And in that setting, mammography is not as sensitive for picking up breast cancer at its earliest possible stage. So the way that MRI works is that we all have our entire bodies are made up of water. Not to get into the physics, but the protons are spinning. You send a pulse, right, and then the protons are going to be knocked off their axis. And the MRI machine is going to pick up the different ways or the different timing at which the protons then come back on their axis, and that's going to tell us, is there something there or is there not something there? When you put the contrast into that equation, you're going to be able to see, is there an entity that's picking up blood flow? that's abnormal as compared to the rest of the breast, because we know that breast cancer is a pro-angiogenic state, meaning that breast cancers are going to make their own blood vessels, and they're also going to recruit blood vessels within the breast. So wherever there's increased blood flow as compared to the rest of the breast, we're always going to take an extra look at that as being possibly suspicious for evaluating for a breast cancer. And you're not going to be able to get that detail with a mammogram or with an ultrasound.
Right. Allison, the decision to choose either prophylactic mastectomy or screening, evidence-based screening.
Door number 3, please.
It really is like one of the central dilemmas, right? And so it's deeply personal, and it goes without saying that there is no right or wrong, but as you pointed out with testing, it can be the source of thorny tension, even in the most loving of parent-child relationships. So I like to say that good relationships are defined by how well and honestly we care for one another. And if that's the case, how do we reconcile radically different approaches to the same circumstance? And something that someone brought up about keeping the locus of power in the hands of the individual, how important is that?
So it's a lifelong decision. This is one you don't turn back from. So the person who's having the surgery and making that decision needs to be at the steering wheel, and period. Now, that doesn't mean I'm going to mix metaphors. That doesn't mean there are not a dozen other cooks in the kitchen, right? And at this age, we're not just talking parents. We've got life partners. We are the only species on the planet that has in-laws, right? So we are talking about all sorts of things with all sorts of people and all sorts of opinions, and figuring out how to wade through all of those opinions to make a good decision. And we think of autonomy as the hallmark of ethical decision-making in the medical context, but autonomy in this situation, when a condition is in the family, when the risk is shared in not just in our genes, but in our shared loss, our experiences of illness and caregiving, it's near impossible to make decisions that are isolated from our circumstances and our contexts. So I want to back up just a bit from the yes or no question and say that mammogram and MRI, these are very intimate ways of knowing our bodies, technologically. And to think about using these and they save lives every day, right? What comes along with that, though, is at a time in the life cycle for young adults who are just getting to know their bodies themselves, how their bodies work, what it feels like physiologically, what sensations they experience head to toe when something is off, what is something that is passing versus here to stay. And a lot of those sensations, especially in the breast area, in our pelvic region, right, we don't necessarily know how to interpret those on a daily basis. And in the context of this uncertainty, that's terrifying. Or at least it can be terrifying. So, and also at this stage of the life cycle, young adults are developing lifelong health behaviors. We're learning to take care of ourselves. From basic hygiene to exercise to diet to what kind of lifestyle and movement we want to experience in the world. So much is happening and coalescing around this decision to keep or remove breasts. Some women, because of their family histories, often think, I have a couple more years, I can keep them. My mom was this age, my grandmother was this age. I'm going to leave those questions to someone other than me on the panel and in this room. But that's part of the story that I hear regularly. Understanding time left, or the window of time, or what I've called danger zones. When am I in a space when I need to start really worrying? But all of this is about a lifelong relationship with your body. And part of what's hard to talk about in this age, how many of you have had those conversations with your adult children or with your parents? SEX. We like having the breasts. They're lovely. They're fun. They make nice pillows. They help our clothes fit in very special kinds of ways. Sometimes they get in our way. Sometimes in yoga, I think I'm going to smack myself in the face and knock myself out. We never really know, but these are a part of our relationships, right, with our bodies. And so these are to put that on the table in these conversations with all of the cooks that are in the kitchen is nerve-wracking. Yeah. It's hard, especially if you've grown up in an environment where sex and body image and body positivity has not been on the table. And in this culture, again, we are not taught that our bodies are really our bodies are commodities, really, right? So women are judged largely based on our appearance, our bodies, our physicality, our sexuality. So these are complicated decisions. They're not snap decisions. And often we need to come to terms with the decisions around surgery in our own time and in our own ways. Parents may feel rejected by that process. If you're not talking about it with your child, that does not mean your child is not thinking about it, right? It means they're not thinking about it out loud with you in that moment. And
think
that's
also,
a very different,
I think it's also like end-of-life issues or any other issues where people make radically different choices even though they're in the same circumstances. And I think that's a big challenge here, especially when it's your child. Samantha, breast radiologists like you, you had said it, Allison, earlier, the skill and expertise of breast radiologists save so many lives. And I think we all go in for our mammograms and we kind of have that expectation, but it is quite extraordinary. But radiologists like you are often the first person to tell a woman, or a man in the case of BRCA, that they have cancer. And so can women feel good about choosing surveillance over mastectomy?
Absolutely. MRI and mammography together have been shown to be able to detect breast cancer at very treatable stages. And I think if you are of the mindset that you want to pursue aggressive screening, screening is a very good choice. What comes with screening, though, is unfortunately false positives, right? And so when I'm counseling patients who are making a decision, if they're not BRCA, but they're talking about getting supplemental screening, and we're talking about MRIs and how MRIs may help you if you have dense breast, I always tell them that a breast MRI is the best test to find breast cancer at the earliest possible stage, but it finds a lot of things that are not breast cancer. And when you find something that's not breast cancer, you're still going to need a biopsy. You still might need 6-month follow-up. You might need to keep coming. And thinking about the emotional toll that could take on someone, who's also experienced it with a loved one, right? If you are the child of someone who's had breast cancer before, you perhaps could have experienced what it was like for your mother, your aunt, your sister to have to undergo those tests. And you have that shared anxiety with them, right? That when you yourself have to undergo that test, even if it ends up being negative, it can still weigh on you, right? And it can still really impact your quality of life. And so I do see with my patients that are BRCA or have another mutation that are considered high risk, and unfortunately they keep growing things in their breasts when they're young because it's normal to make benign masses before you go through menopause, right? That it is a lot. And so we have discussions as to, maybe you should talk to your doctor about like other things that you could be doing if you don't want to pursue this. So I do think that screening is great. Screening is amazing, but it comes with these other not great things and side effects. And so as long as you come from a place where you're willing to accept these false positives and you're okay with undergoing extra testing, even to be told everything's negative, then you should continue to pursue screening. But if you come from a place where you've had one too many biopsies, you've had very negative experiences, and you say, maybe I've had enough.
I'm done.
Yeah,
right.
Exactly. I think that's appropriate too.
And MRI screening remains the gold standard, though. Yeah, so it comes at a cost.
Yes.
Tell us, are there any emerging advancements in breast screening imaging that show promise for early detection?
Absolutely. So I'm sure everyone saw the New York Times article, maybe it was like 2 months ago. The headline, it was the front page, AI will replace breast radiologists, right? Yeah. I won't have a job in a couple of years.
AI is the next moderator.
Exactly. No, I think AI, artificial intelligence, is really moving along within all of imaging, not just breast imaging. It's helping me become a better breast radiologist, and we're actively employing it now at Penn. We have a new modality that is overlaid on our mammography that learned from a data set that had enriched cancers. So it can tell me the probability on that mammogram of what it thinks that there is a breast cancer here, and it can show me which ones it thinks are the most suspicious on a 0 to 100 scale. It's not perfect. It's not perfect at all. But it does does pick up a lot of breast cancers, and it is very helpful. And so I think technology like that is only going to make us better radiologists. It's going to decrease our false positive rates, and hopefully it'll allow us to pick up the breast cancers even earlier than I would have been able to pick up myself. Another thing that we're working on is detecting a breast cancer before it even appears on the imaging. So we're able to now tell, based on the texture of the breast, the density of the breast, pull in information from a patient's history as to what kind of biopsy they've had before or family history, and then look at that mammogram and say, while there's no breast cancer here right now on this mammogram, we think that this person could develop a breast cancer much sooner than someone else. And so that type of information is in the pipeline and is working and will help us to make more tailored decisions when it comes to screening and how often we should be screening, or could help sway someone in a decision to have a mastectomy if they were of a BRCA mutation.
And what about in your practice? Do you see the tension between young children, adults and the carriers and their children? Do you see this tension that comes up?
I see I see young women all the time who have had parents who have BRCA mutations, and they themselves either have not been tested. Dr. Domchek and I share a patient actually who's one of my friends whose mother, or there was a family history of colon cancer. Through Cascade testing, someone got tested, another person got tested, and then my friend was tested and was a genetic mutation carrier. And in having discussions with her as to when she should start screening or not start screening, and thinking about what happened to her family members, there definitely is a tension. And it's not one size fits all, right? And a decision that a child makes could be very different from what a parent makes.
Interesting. Allison, you hit on this a little bit about sexuality, but parents are likely not thinking very much about, or at all about their adult child's sexuality. But there are real issues around sex and identity and femininity that come up. How can parents talk to their children about this?
Xanax. No, I'm sorry. It's one of the hard things we talk about with our kids. It's one of many hard things we talk about with our kids. As a comparison, I have friends who say, oh my gosh, I'm so worried that they're going to have sex early. I'm like, sex is going to be a part of their lives. We are all sexual beings, right? Drugs may or may not be a part of the risks that we see down the road, but sex is definitely out there at some point. So there are resources for talking with your kids. And like all the other conversations you have with your children, and for those of you who are in the room who may be thinking about children at some point in your parenting trajectories, start slow. Start small, go slow. And recognize that the bounds of your comfort are how you grew up, and your children may actually help lead the way in some ways because the conversations they're having with their friends are different. Sexuality is on the table, and then of course reproductive decision making and how we're going to plan our families is on the table. And again, so many cooks in the kitchen. So these conversations, and the relationships that we have with our bodies are multiple. They're varied over the life course in so many different ways, right? Our bodies look so different than they did 10 years ago, no matter who you are or how old you are in this room. So our perspective about our bodies, the way we enjoy our bodies in movement, in silence, in meditation, part of this conversation and thinking about surgery, just to go back to that question and kind of tie them together, is figuring out how to live with the body you have, and if that body has had surgery, and to find grace and generosity for yourself and your body and what your body can do.
And does this issue come up with your patients post-mastectomy in terms of sexuality? How important is that in the decision making?
I don't often see. I don't often talk about sexuality with my post-mastectomy patients. I'm usually seeing post-mastectomy patients when there's an issue, because something to think about is after you get a mastectomy, you no longer get screened for breast cancer. That there isn't evidence for screening patients after they've had bilateral mastectomies, even though there's still some breast tissue that's left behind, right? So if you have a bilateral mastectomy, your risk of developing breast cancer drastically decreases, right? 90 to 95% decrease in your absolute risk of developing a breast cancer. But unfortunately, I still see women who, after they've had bilateral mastectomies, they still can develop a breast cancer. Both women who've never had breast cancer
so
before
tragic, yeah.
and women who have had breast cancer
Right,
before.
and I think you also told me a story about a patient who had to choose between bilateral mastectomy or breast conserving treatment, and they chose
Right.
BCT in order to get the screening.
Exactly. So the thinking and the literature has shown that if you are a mutation carrier and you do develop a breast cancer, the usual recommendation is to have a bilateral mastectomy because your risk of developing another breast cancer is very high as well. But I spoke to a woman who I see every year for screening who was so afraid of not having screening anymore, right? Or at least not having imaging, just having physical exam, that she said, I would rather keep my breast or keep one breast, right? Knowing that at least if I have one breast, I can still get an MRI every year to be evaluated for breast cancer, and I'd still be getting a mammogram. I know Dr. Domchek has conversations with these people all the time, and she counsels them, that they probably should get double mastectomies, but that is an opinion and is a strategy that some people have.
It's also really reflective about, again, people making radically different choices in the same circumstance.
Can I jump in there just briefly? This is also about coping with that uncertainty and that anxiety. So in this moment, a referral to a mental health provider can be really, really helpful.
Great advice.
And bring in someone who can help sort through what meaning the screening has, what meaning the surgery has, and how to make a decision that meets the variety of medical and emotional needs that are on the table for you.
Thank you. Thank you so much. Let's move on to Dr. Isabel Bloomberg. Isabel, your practice is made up of girls and women of all ages, so you have a long view of what it means to be BRCA throughout different stages of life. You also bring a personal perspective. Can you tell us a little bit about your history?
Sure. I myself had breast cancer at 45. I'm not a BRCA carrier, but it turned out my sister had breast cancer at 45, and my mom had breast cancer at 60, and my grandmother had cancer at 80. So there is something in the family. We just don't know what it is, and there's a lot of that out there. So I do think, I know what it's like to get in the MRI machine every year. And I will tell you that breathing exercise, if anyone doesn't know how to meditate, if you learn how to meditate, it makes the MRIs much, much easier. Okay? Piece of advice. But yeah, so I do understand what it's like to be a cancer patient. I do understand what it's like to choose surveillance versus doing mastectomy, because that was the decision that I chose, to do a lumpectomy and radiation versus mastectomy. And I made that decision with my surgeon, with my husband, for a variety of reasons. And every patient is different. One thing I think we forget sometimes in nights like this, BRCA is just a part of who you are. You have so many other things going on in your life. You have other medical issues. You have fertility issues. You have things that are going to come up in your medical history that will guide you in other ways. So BRCA is just a part of it. And we have to incorporate that and be respectful of it and use it, but it's just a part. It's one part.
Well, your story, like your patient's story, shows that all of these choices are so courageous and brave, and there is no right answer. I always talk about the t-shirts I want to make up that say, there's no one way to do BRCA.
I love that statement.
So let's talk about, and thank you for sharing your story. Let's talk about ovarian cancer and screening and the limitations of ovarian cancer screening, which is sadly still the case, and it is the cause of so much poor outcome that we see. What are the recommendations?
So the recommendations are to start screening at age 30. Obviously, if there's a family history of somebody having ovarian cancer younger than 40, we would do earlier screening. Usually it's 10 years before the youngest person was diagnosed with ovarian cancer in the family. The screening for ovarian cancer is not as robust as the screening for breast cancer. So we don't have this combination of MRI and mammogram that we can do for ovarian cancer. And ovarian cancer is insidious. And the screening that we have is usually ultrasound twice a year. But you could have a normal ultrasound, and 3 months later you could have development an ovarian cancer. It's really hard to screen for. Blood testing is not reliable, and especially in premenopausal patients, the blood test, CA125 is the blood test I'm talking about, which you guys have probably heard of. We use that usually for screening patients who have had ovarian cancer to see what their response to therapy is and to make sure that they're at undetectable levels after treatment. Using it as a screening modality is not that good, and it will fluctuate within your cycle. So, and then what happens is you get back an elevated CA-125 and you send the patient for imaging, and then the imaging doesn't show anything, and then what do you have? You don't have something concrete. And those patients will end up with unnecessary surgeries. So it's really tricky to tell patients, about screening for ovarian cancer. The gold standard for the reduction of risk for ovarian cancer is bilateral salpingo-oophorectomy, and that's surgery where we take out the tubes and the ovaries, and that would be done by an oncologist. I'm a general OBGYN, so I scrub in on those cases with my patients with an oncologist, but I would send any patient who needs a BSO with a BRCA carrier should see a GYN oncologist for that surgery, not a generalist. So that's the gold standard, but then obviously that puts somebody into menopause, or it takes away their fertility if you take out their tubes and ovaries. So you have to balance all those things when you're talking about risk-reducing surgery for ovarian cancer.
Right, right. And in the area of risk-reducing surgeries, things are rapidly changing, right? So studies have shown for quite some time that some ovarian cancer begins in the fallopian tubes, and there are varying opinions about this right now. We're kind of in flux, whether patients should remove their ovaries or they should just remove their tubes. And can you tell us what's going on with that and where we stand?
We know for all BRCA patients, at some point, they should consider removing their ovaries, because that is really the gold standard for reducing the risk of ovarian cancer. But where it becomes more nuanced is when somebody is premenopausal and doesn't yet want to, feels conflicted about going into early menopause. And so in those cases, sometimes if somebody's a good surgical candidate, you could do risk-reducing removal of the tubes, bilateral salpingectomy, and leave the ovaries so they still have their natural hormones, and then later go back for a second surgery to take out the ovaries. And you would still do the ultrasounds after that. So you're still getting the twice-a-year ultrasounds because the ovaries are still there. But there is this data that shows that ovarian cancer starts at the fimbria, which is sort of the fluttery ends of the tubes, and if we can take those out, we may reduce the risk of developing ovarian cancer in this population. So now, for example, when we we used to do what's called a tubal ligation, when patients wanted to have their tubes tied at the time of C-section. We take everybody's tubes out completely now, even if they're not a BRCA carrier.
That's so
because
interesting.
it's a risk-reducing surgery, and why would you?
And they serve no purpose.
Why would you leave that part of the tube in there? So we take the tube out completely, and we've been doing that for a while now.
I want to just stop for a second. This wasn't a prepared question, but I want to talk about menopause for a second and surgical menopause. And can you talk about what that experience is? And because for a long time, the option for fallopian tube removal did not really exist. Right. That's relatively new.
So menopause is when a woman's ovaries cease function. Usually happens somewhere in between 45 to 55, and their ovaries will slow down over time. And eventually their ovaries will stop producing estrogen and progesterone. And when that happens, and a woman has not had a period for at least a year, she's considered in menopause. The years leading up to that, perimenopause, are when your periods become more irregular, the hormone levels fluctuate more, and a lot of women will have symptoms related to perimenopause and menopause, okay? And you've probably seen a lot about menopause. Somebody said to me the other day, it's like the billion-dollar idea.
Yeah.
Which is true. So when you put somebody into surgical menopause, when you take out their tubes and ovaries, and they've had fully functioning tubes and ovaries up until that point, they're going to stop producing estrogen. They're no longer going to have that endogenous source of estrogen and progesterone that the ovaries were producing. It's like hormones. Taking those hormones away very abruptly will give you very strong symptoms of menopause immediately. So, I think what's really nice about this data that's coming out about the salpingectomy, just taking out the tubes, is it allows us to delay that a little bit till women get closer to the age of natural menopause, because the recommendation is, was to do a BSO, bilateral salpingo-oophorectomy, as early as 35. Most women don't go through menopause at 35.
No.
And there are risks associated with going through early menopause, like osteoporosis, heart disease, things like that. So you kind of want to keep your ovaries and your hormones as long as you can. And then you start to balance the risks of taking out the ovaries, taking out the tubes with with menopause.
Yeah. Allison, before people are ready to take a surgical step, the lack of real surveillance for ovarian cancer that Isabel was talking about can be very anxiety producing. And this is often in combination, as we've been talking about tonight, for breast surveillance and sometimes even for pancreatic surveillance. How can parents support their adult children in this kind of merry-go-round of worry?
So, again, the whole screening endeavor, the whole relationship with BRCA, there's so many ways to do BRCA. Open communication, keeping those pathways open, and putting the issues on the table for discussion are going to help. So silence breeds silence. So in families where you're not talking about cancer, where you're not talking about screening, where you're not talking about the history and what feeds and fuels the quiet in families, your young adult children are going to, and teens and even very little children are likely to recognize that there's anxiety, that there's distress around these topics, and stay away from them in the service of protecting you emotionally. Again, it's out of love, it's out of care, but it's also learning the rules about how families talk to each other. So it can be as easy as just saying, you know, you can ask me any questions and we can have a judgment-free moment together. And setting the stage like that for their children. One of the things I recommend for parents when they have difficult conversations with their younger children, although this works for older ones too, is to trap them in the car. Now, I know this is hard in New York. But here's the benefit. Here's the benefit. These are intimate, intense conversations. When you're in the car, you're not looking at each other. You are sitting side by side, and that reduces some of the intensity. Unless you are driving to California in an electric vehicle that can be repowered by the sun, eventually the ride will come to an end. So it is a truncated conversation. And if you have these conversations at night, you can't even see each other's reactions. So you laugh, but this is actually how I encourage parents to talk to their children about really hard things. It turns out the other place is to take them out in public. You don't wind up yelling at each other if you're sitting at the diner over cheeseburgers. But I think that there is something to be said for finding a special place that is not where the rest of family business happens. Whether it is a walk or a park or a cafe or a part of your home that isn't imbued with all of the wonderful and warm things that also happen in your house. My children know if we're going into mom's office, it's about to get real. Right? There's going to be a conversation. But that also means they know they're not going to get ambushed at the dinner table. Right? So framing the conversations in ways where expectations can be set, where ground rules can be established, and where those boundaries around the conversation can be respected is critical.
Yeah, I also think it's interesting because many of the women who were diagnosed, 15, 20, 25 years ago didn't have all this screening that we have today. So even though you might have a mother and a daughter who are both BRCA, are carriers, their experience of surveillance is very, very different.
Absolutely
And
different.
the added worry and the tension, yeah. Isabel, for many young carriers, a mutation forces them to think about something that they probably weren't thinking about, which is having children of their own. And once again, this is deeply personal, but let's talk about reproductive technology and pre-implantation genetic diagnosis, or something that's called PGD. Can you tell us about it and what you're seeing in your practice around it?
Sure. So as everybody here knows, you have a 50-50 chance when you're a BRCA carrier of passing that gene onto your offspring. And this is a dominant gene, meaning that your child only has to inherit one copy from one parent to be an affected carrier. So when patients are BRCA positive, some patients will opt to do IVF, where they take out their eggs and they fertilize them, and then they test those embryos to see if those embryos are BRCA carriers, to decide whether or not they're going to put back an embryo that has BRCA. It's really variable, and some people find out they're BRCA carriers after they've already had children.
Right.
Some people find out before. We're talking to the young families, so people in this room will possibly find out before they've had kids. Not everybody wants to do IVF for BRCA. It's not a universal, and some people feel really strongly about it. I have one patient who is single. She has already taken out her tubes. She has frozen 80 eggs. She's done multiple cycles. And that's where her head was at. And she actually came to me because she was with another doctor. She's fairly young, and that other doctor could not understand why she was being so aggressive. And I was like, this is what you want to do. This is how, and she had good surgeons, she had good counseling, and I was like, that's fine. So it's very variable for everybody, and not everyone will want to do IVF for BRCA testing, but it is an option.
Allison, older parents want to become grandparents, in my experience, and PGD brings
Not
up...
yet, Ethan. Thank you. Yes, positive.
PGD brings up a lot of issues. Unsolicited advice is not always welcome. I like a joke that says, by the time a daughter realizes that maybe her mother was right, she usually has a daughter of her own who thinks she's wrong. Seriously, though, how can we navigate these discussions with daughters and also sons who may not have even tested?
Right. So this is where the generation gap in technology really becomes poignant in the home. So I've had so many young women, mostly women, some men say to me, if this technology was available when my mom was having me, I wouldn't be here. And I believe that my life is worth it. My life has been worth living, and I wouldn't change this about myself.
Yeah, so that unintentional, hurtful message, you know, really
it's real.
Speaks about how do you navigate around those waters even with the best of intentions, right? That message that these kids are getting, that's a very real experience.
It is, and it's important that young adults hear the message that is actually being communicated, because it can be so hurtful. What a parent is saying in that moment is not, I wish you hadn't been born. That might be in a different conversation. That's not what's happening in this conversation. What's happening in this conversation is, I love you and I don't want you to struggle and suffer the way I have suffered and struggled. I want this to be easier for you. That's what your parent is saying. That's not, as parents in this room know, what you say is not always what they hear, right? Right. So these decisions, and it's important to understand, right, that the technology exists. It is expensive. It is unregulated. The insurance coverage is spotty. So this isn't really a viable option for many people who have a BRCA mutation or any kind of genetic mutation they would like to screen out. Now, I come from an Ashkenazi background. BRCA was not nearly the only thing in my family history that might have been screened out. And I've had young women say to me, if I could get rid of something, I'd take away my anxiety. Take that, leave me the BRCA mutation. Anxiety, and it's funny, but my anxiety is every minute of every day, and BRCA is a couple times a year.
And yet, you know, you do, in all seriousness, you do have generational trauma where people get to the point where they say, I've watched this over 3 generations of my lifetime, and it stops here.
Absolutely, and this is where that individual pathway and understanding your family history is so important. So when I talk to women who've lost a mother or a grandmother or a sister or an aunt, their perspective on how to take care of their bodies is often different. In my own family, my mother's a BRCA1 mutation carrier, but she's never had breast cancer. She had colon cancer in her 50s, so I went into reproductive planning thinking, I'm good, I'll find out later. Thank goodness that was not an issue for me health-wise, right? It was okay to move through that space. And I had 2 boys, and I thought, whew, I didn't know them well when I said that, now I do, but then we decided we wanted to try for a girl, and it felt like taking a huge risk, right? And that's actually when I decided to get tested myself. It turns out I do not have a BRCA mutation, but I continue to do this work because of how critical those moments and those decisions are. But I had considered PGD. And actually, I told you I come from I married into a family of gynecologists, and there were opinions. So, and figuring out how to manage that with the emotional resources in the family, the investments, the agendas, and I say agendas, but not in a manipulative way, the hopes, the fears of the people who love that couple or that soon-to-be parent are all on the table. And so what I want to encourage would-be hopeful grandparents to think about is that there are a lot of ways to make a beautiful family. There are a lot of pathways towards parenthood that gets you a little snuggly something.
You've spoke. Oh, go ahead.
Oh, I was just going to say, I think the other thing too is, you mentioned this, Allison, but just the family history is so important in terms of what decisions people make and when they make them and how they make them. I had a young woman who tested positive. She was 26, and she said, I don't know why everybody gets so upset about this. My mom had it. She had breast cancer. She survived. My grandmother had it. She had ovarian cancer. She survived. My aunt. Everybody in her family had been lucky enough to survive their cancers. And she thought, yeah, you get it, you move on, no big deal. Versus anyone who's experienced a loss over anything, you feel that so desperately, and immediately that cancer is associated with that mutation, and that feels so much more real. So I think that plays into every decision that our carriers make and every conversation that our carrier families, because they're a unit, that they have. And the sister who doesn't have the mutation, who feels like, I have to protect you now, so I'm going to tell you to have every surgery because then you won't have what mom had. And so I just think the family history and the family dynamic is so huge. And our kids look to us. My daughter had her wisdom teeth out this morning. She said, you had yours out. What did they do? Did they stick you with the needle? How big was the needle? This is conversations. They ask us everything. And so I think making a conversation about, did you ever have an MRI? What was your breast surgery like? People like to look, touch. Everybody learns in different ways. So I think if your kid is asking, that's such a huge step in their understanding and their decision. They may not do what you did, and that's okay. But I think they're looking to their entire family
100%.
Unit as a resource of someone who feels safe. And if we don't become that safe person, it becomes very difficult for all of our kids to navigate.
People think that this is a science, and they're looking at risk, right? 87%, 64%, whatever it is. It's really so much has to do, decision making is around family history and what they've seen, their experiences.
And then the decisions can become motivated by grief. And that becomes challenging. And not just grief over having experienced loss in the family, but thinking about anticipating grief. So and I think I spoke about this briefly last year. The idea with anticipatory loss is we begin to mourn changes before they happen. We begin to rehearse, to prepare, to experience them quite profoundly before they happen. And this ties back into prophylactic mastectomy. There is mourning and grief around the loss of
100%.
breasts. There is mourning and grief around the loss of the security that the MRI can provide, right? So much so that that experience motivated a treatment decision.
Oh, absolutely.
Right? So, and that kind of anticipatory loss pervades so much of this experience, and naming it is an important part of managing it, of coping with it.
Yeah, I mean, traditionally anxiety was not a criteria for surgery, right? Like in the past, before BRCA, I always like to say that medicine had a very predictable continuum. You know, there was a symptom that somebody had, then there was a test, and then there was a diagnosis. But BRCA really turns that whole trajectory on its head.
And we don't need anxiety to manage our BRCA mutations well.
Yeah.
We don't need anxiety to manage it well. So we can think about our mental health and our physical health as separate, parallel, and interlinked trajectories. We can often do a lot of work on the mental health side, develop coping techniques, connect with communities that understand the experiences like you have all coming here tonight, and in that process, come to terms with the kinds of decisions we need to make to maintain our health.
Going back to PGD for a minute, you've spoken and written, I think, about the pressures of new technology. And, you know, it can rob young people of so many experiences. Can you talk to us a little bit about, I think, Susan Domchek, you like to say there are a lot more fun ways to make a baby.
Amen.
And cheaper.
And cheaper. And now we're back to an earlier part of the conversation. So the idea around technology and pressure, it's called that a colleague of mine, Judy McCoy, who's on the faculty at Rutgers, talks about the technological imperative. And the idea is that the presence alone of a technology implies a moral obligation to use it. So the idea that PGD exists pushes us to consider using it, even if we would have had no intention of that. But and this is complicated, but with PGD existing, we don't use it, we have made a very clear decision. And embedded in that decision can be blame or shame or guilt about permitting the birth of a child who is affected by a familial mutation. So the presence of these technologies is wonderful and glorious and enables choice, but it also can incur burden and pressure. And so it's important to think about those pieces, about what's really important as you make a family, And what you really want to preserve, is it the biology? Is it the shared identity? Is it the culture? Is it the shared beliefs and experiences? There are so many ways to go about it.
Thank you. Isabel, finally, do you feel like you see the tension come up in your practice among families?
A little bit. I mean, I have patients in my practice where I have one relative who's affected, a sibling who's not affected.
That's a hard circumstance.
It's a hard circumstance. It's a different conversation, obviously, from patient to patient. The PGD question and the IVF question is a big question for people. And they are really, there's so many opinions, and it's very, very mixed. And what I say is, you have to do what's right for you. And if you don't want to do IVF, you don't do IVF. If you can't do IVF, you don't have to do IVF. And then there are people who need IVF for other reasons. And
right, it's not
PGD,
the only.
Exactly. There are people with BRCA who also have fertility issues. So, IVF comes up for other reasons, and then PGD just becomes a part of it.
I think at one point there was a study, maybe Susan, you can comment on this, about BRCA mutation carriers and fertility issues.
Premature infertility.
Yeah, there has been this long-standing question about whether or not there's earlier menopause or fertility issues, and there may be slightly earlier menopause, natural menopause, but to be frank, we don't really let our known BRCA mutation carriers get to that point. And there hasn't been actually really compelling evidence of if you're just getting pregnant naturally a fertility issue. Having said that, if you go through IVF, there tends to be just fewer embryos generated, which adds to another thing, and Isabel, you may comment on this. People can go through PGT and be left with no unaffected embryos. And I actually really warn people about that, because there is nothing worse than making a decision to go in that direction, being a completely healthy young woman who could get pregnant on her own, and then going through all that and then not having it be successful.
You do have to go into it knowing that. I think that has to be explained by the reproductive endocrinologist or the gynecologist, that you can do IVF and make no embryos that are unaffected. You can make no embryos that are, they might be BRCA negative, but they have other chromosomal rearrangements or abnormalities, so you wouldn't transfer those embryos anyway. And we've had patients where that's happened. And
what do they end up doing?
She had another baby. Like, she had 3 kids or 2 kids, and she went to do IVF for the subsequent child because she found out she was BRCA positive in the interim. The IVF was unsuccessful, and that's it. There's another baby in the world. It's a good story.
There are another number of ways that these can get complicated in families. For those of you with more than one child, I've spoken with women who say, I want to use PGT, but my sister can't afford it.
Oh,
and that puts me in a really strange position, because I can't afford it where I am in my life, and can I offer my children something that my sister can't?
Wow.
And then the other story that I've heard in that vein is, as you had mentioned earlier, people testing after they've had a child and thinking, oh my goodness, I should do PGT now if I want to have another child, but they didn't do it for the earlier ones.
Right.
And so now they feel like they're treating their children differently because they have more information to move ahead with family planning than they did before. And so these are just a few examples of the ways that these decisions are so complicated.
Oh, gosh.
And again, I know it sounds so simple to say, just sit down and have a conversation over a cup of anything. But really, just sit down and have a conversation. Start the conversation. You can start it small. Start the conversation with tiny pieces of information seeking. I have a colleague who works fully as a clinician outside of the DC area, who's actually participated on these panels before, and she says one of the things she does with families is she has them go out and do research about all the different ways to become a parent, and then systematically has parents go through and identify their values for each method and rule them in or rule them out as options. And so they participate fully in deciding how they want to become parents.
Wow. That's like an Excel spreadsheet.
Completely.
So interesting. Thank you all so much. We're going to move on to some questions that have come in from the audience. Thank you.
More questions?
Anyone else have any? This is for Susan Domchek. We have a history of pancreatic cancer in our family. What are the screening recommendations, and at what age do you recommend they start, I assume?
So pancreatic cancer screening is one of the really kind of hot topics, and there's not complete consensus. So just to give you an idea, sort of the most common guideline in the United States, called the NCCN, recommends pancreatic cancer screening starting generally at age 50 for BRCA1 or 2 mutation carriers who also have a family history of pancreatic cancer. Okay, so, and again, that's either with an abdominal MRI or something called an endoscopic ultrasound, when a probe is placed down into the stomach and you kind of look from the inside out at the pancreas. So that's sort of the if you will, in the US, that's a group of individuals where their insurance will cover the cost of testing, although, you know, there's deductibles and copays and all that kind of stuff. Individuals who have a BRCA1 or 2 mutation and don't have a family history of pancreatic cancer, different US guidelines say you should get screening, but the NCCN does not say that. So that's an area where there's not consensus, and the insurance won't necessarily pay. It's a lot of screening, and so, like, just to give you a sense, in a big publication, like 1,400 people got screened. These are people with a family history of pancreatic cancer, and 0.6% ended up being diagnosed with pancreatic cancer. But for those people, it mattered a lot because they were diagnosed with an earlier stage. So it's just messy. And then in Europe, they don't screen anybody. And so we're still working on this. We're trying to come up with better tests that are less invasive so that we could do the screening more often.
I have a question that you talked about. With most surveillance, it's not dangerous. There are no complications. But with endoscopic ultrasound, are there potential complications?
Well, there's, you know, every screening test has the potential for harm. So for abdominal MRIs, and by the way, Sam got away without answering the gadolinium question.
Yeah, I noticed that.
Yes. But, you know, abdominal MRI, you do get additional gadolinium. There's also there can be a reasonable number of false positives on abdominal MRI. You know, you can see things in the adrenal gland, you can see things in the kidneys, they require follow-up tests and the like. Endoscopic ultrasound is not an ERCP, and I think this is where, the ERCPs do have more complications. EUSs generally have a low complication rate, but you do, you know, it's like a colonoscopy. You don't have to prep like a colonoscopy, okay? But you do get, you know, that propofol, so you kind of take the nap and you're out. So there is a small risk of complications for that as well. And the gadolinium question?
Yeah, thank you. Let's go back to that.
Yes. So gadolinium is a metal that is used in MRI. MRI works as a magnet, right? And so that's how the gadolinium attaches to the red blood cells, and that's how we're able to see where the increased blood flow is. The gadolinium on your red blood cell travels all throughout your body. And so there are studies that have shown that after patients are given a gadolinium injection, if they were to get their brain imaged, we can see some of this metal deposit inside of their brain. We see it more often in people who do not have intact blood-brain barriers, so people who've had prior brain surgery or maybe have an inflammatory disease such as like multiple sclerosis, but we also see it in people with intact blood-brain barriers. There are different types of contrast that we can use. There's linear contrast, there's macrocyclic contrast. The contrast that we use at Penn is called deuterium. It's a macrocyclic agent, and the amount of gadolinium that could potentially be deposited in the brain is very, very, very low, something like 0.000 something of the injected dose. And what they have seen is that when those patients then get additional MRI studies, there is clearance of that contrast from the brain. So the body's able to get rid of it. We also know that it gets deposited in our skin, in our hair. It goes anywhere that blood goes. They've done some neuro studies on mice. I don't know how one does that, but they've done it, where they've like measured their anxiety and also like their abilities to like do reasoning on the wheel, whatever. when they get gadolinium, and they haven't seen any differences when they gave mice like 100 times like a human dose, like something like outrageous, and then they imaged their brains and they saw a lot of deposition and there was no neuro consequence. So it is something that happens. We know it does travel all around our bodies, including in our brain, but as it stands right now, there's no evidence that it causes any kind of neurologic impairment, and our body does clear it naturally.
Thank you.
I love science.
This is for Susan and Isabel. There's so much conflicting information on birth control and hormone replacement therapy. Does it increase or decrease breast and ovarian cancer?
Well, all right. So birth control. So, again, let's go back to you're BRCA positive, but you are 21 years old and you're sexually active, right? You need birth control, okay? Let's start from the beginning. So again, you have to look at the whole picture. And so those patients need birth control because they need some form of contraception. Hormonal combined birth control, which is estrogen and progesterone pills, decrease the risk of ovarian cancer. So when you take that for several years, you really reduce your risk. So in a BRCA patient, you can actually reduce the risk of ovarian cancer by giving them birth control pills. There is a slight increased risk, lifetime risk of breast cancer when you take combined birth control pills or use a progesterone IUD. Any hormonal form of birth control slightly increases your risk of breast cancer. But we have really good screening tests for breast cancer. And again, you need birth control, and we're going to reduce your risk of ovarian cancer. So there are really good benefits to being on hormonal birth control when you're young. HRT is a little bit more complicated because patients who go through premature menopause or menopause at any point may want to go on HRT. If you've already had breast cancer, like an estrogen receptor positive breast cancer, you are not a candidate for hormone replacement therapy, okay? Talk to me if you want to talk about going through menopause and not getting HRT. I can you will survive. But after, let's say you do a BSO, take out somebody's tubes and ovaries, they may want to go on hormone replacement therapy. A lot of places feel, unless they have a mastectomy, and Susan, you can correct me.
I'm okay with HRT.
Me too.
Yes.
So I think, again, we have really good screening modalities for breast cancer, and this population is going to get screened religiously, right? So you can go on HRT at that point. The question becomes, if you still have a uterus, you have to get progesterone as well as estrogen. So when you do somebody's tubes, take out their tubes and ovaries, should you be taking out their uterus? And that becomes an ongoing conversation with the oncologist, because if you take out their uterus, you don't have to give them progesterone, they can get estrogen only. And studies have shown that estrogen only does not have as high a risk or increased risk of breast cancer as a hormone replacement therapy.
Yeah, I really have not much to add, except I feel very strongly about the oral contraceptive issue. There are good things about birth control pills. They decrease ovarian cancer risk. People don't get pregnant. They control cycles. They control acne. They control mood. There are bad things about birth control pills. There's an increased risk of blood clots. There's this slight increased risk of breast cancer. So everything in life, it's nuanced, but particularly in this day and age, we should be, making sure that our young women in our family have adequate contraception. And the hormone replacement thing, I have people that, this whole salpingectomy thing, the tubes only, it's really compelling, but right now it's still the standard of care to take the ovaries out. And we're still taking them out. The good news is now, for BRCA2 mutation carriers, their risk of developing ovarian cancer was always low before age 45. And I think now people feel more comfortable if the tubes are out to waiting to 45th. So that's really good news. But we still take their ovaries out. But we're not taking their ovaries out to make them have no estrogen. We're taking their ovaries out so they don't get ovarian cancer. And we're still going to give back less than they started with. And so I really feel like we will have women say, I'm not going to get my ovaries out because I'm worried about being menopausal. I'm I'd rather give you estrogen and have your ovaries out, right? So that's these are the types of conversations we have that really try to put into perspective what is the problem we're trying to solve. And the problem we're trying to solve is not having people, die of ovarian cancer. So, again, everybody has a little bit of their own perspective on, what they're willing to think. But when I hear from people well, my gynecologist won't even consider giving me HRT. I'm usually you should find a different gynecologist. because it should be at least a conversation.
Yeah, 100%. Isabel, can you talk about egg preservation? Age, risks, hormones?
Sure. So egg freezing is the beginning part of IVF, where you take the eggs out of somebody's ovaries. You see a reproductive endocrinologist. They give you medications to stimulate the ovaries, and then they take the eggs out. If you are going to make an embryo, you have to fertilize that egg with sperm. If you are not going to make an embryo, then you can just freeze the eggs. So you'll take all the eggs that somebody can produce and you can freeze them. I used to tell patients do it at 34, 35, 36. These days, the pandemic really opened up people's lives in terms of having more free time, working from home, more flexibility. And so patients started coming to me during the pandemic saying, I want to freeze my eggs, I'm 29. Okay, that seems really young. But actually, I was talking to my colleagues who are reproductive endocrinologists, and they said, you know what? It's probably not a bad idea if you're going to do this to consider doing it younger. So it's really variable. It's very expensive. It is not covered by insurance at all. Embryo freezing or IVF can be covered if you have a fertility issue. Egg freezing is considered purely elective, and so there's no coverage. Some companies will cover it for their employees. So for example, I have a patient who works at Google, not a BRCA carrier, and she had incredible insurance. And I was like, you should do this. You're 34 years old, you want to have a family, you're not starting a family soon, and this will be covered. You should do this. So egg freezing is when they take the eggs, they freeze them, and then you can later on thaw them, fertilize them with sperm, and make an embryo. So you don't know if an egg is a BRCA carrier. It's just frozen to be used for later. And then when you make the embryo, you can test the embryo. You can't test the actual egg.
It's too bad that egg retrieval is not covered. And that's the next question. Somebody writes in that they have limited insurance and things are very expensive. Allison, what can they do to get mental health counseling?
It's a great question. There are low-cost service providers who work either on sliding scales or with agencies that are grant-funded by large organizations or by philanthropists around the city. So there are networks where you can find folks who will work on a sliding scale and will talk with you about what your income is and what's affordable for you. And when you think there are not a large number, one of my fantasies is to build an army of clinicians, of mental health providers who can do this very kind of specific work. We do not yet exist. So, but anybody who works with uncertainty, anybody who works in the oncology space, anybody who understands grief or women's health, anybody who understands family dynamics is going to work beautifully for you, and you will be the BRCA expert in the room. And that will be just fine. The most important thing in finding a mental health provider who can work with you is someone you trust, that you feel safe with, and that you can be candid with throughout the course of your relationship together.
This question is for Susan. What about prostate cancer screening?
So basically, all the things we haven't talked about yet is good. Keeping us honest. Yes, prostate cancer screening is recommended. BRCA2 mutation carriers, as Dana mentioned earlier, have a higher risk, and it's bad prostate cancer. For BRCA1, it's a little less certain about the relationship, but PSA screening is easy. It's a blood test. Currently, the recommendations are to start at 40. There's sort of ongoing work now about exactly what the kind of target should be for biopsies or what the changes over time should be. But this has gotten better because there's also prostate MRI, which is done differently now. It used to be done, believe it or not, with an endorectal coil, which is exactly what it sounds like. It's not done like that anymore. Yes, it's not done like that anymore. So in people where they often do prostate biopsies now that are MRI directed, so there's sort of a lot less, and there's also more and more work about treating the prostate cancers only that really need to be treated, and kind of, if you will, just watching the prostate cancers that can be left alone, because treatment for prostate cancer can have increased morbidity. So PSA screening, it does actually work.
Tonight, we have talked a lot about the challenges. Susan, I'm going to ask you to stand up again. Can you leave us about what's exciting, what's on the horizon, and what can we be hopeful for?
We've talked a lot about a lot of the challenges, a lot of the really difficult decisions that people need to make in terms of preventative surgeries. And I can only assure you that, at the Pasteur Center, we do not feel that those are good choices, that we want people to have other options for management of their risk. And so we are digging deep on an area called cancer interception, which is trying to, if you will, intercept cancers that at their various earliest stages. It's different than prevention. Primary prevention is you don't smoke, so you decrease your risk of an exposure. This is these cancers are just starting, and we're going to nip them in the bud. Another way to think about it, we use the term, weeding the garden. Take out all the weeds, get rid of them, let things grow again. And so we do have some really clear paths forward for that. We have 2 clinical trials at Penn open right now in this space. One is for BRCA1 mutation carriers using a drug called denosumab, which is an osteoporosis medication, which there's preclinical evidence that it can decrease the risk of breast cancer. And then another trial where we're using a vaccine. This vaccine is targeting something that's overexpressed in 95% of human cancers. And we've actually vaccinated our first 3 healthy BRCA mutation carriers.
Wow.
So we really are, again, it's going to take us a while to prove that it works. So we're not saying that we're done, but we're getting started, and we are really working on this as quickly as we can.
Amazing. Thank you for that hope and faith, as I always like to say. To close, I want to sincerely thank our panel of experts. You guys show us that doctors and providers who care can really be the most trusted confidants and advisors. The randomness of inherited mutations can leave parents feeling very, very helpless and hopeless. So thank you all for being those kind of healers who allow patients to feel good about the experience of being cared for. It's so important. Our panelists are going to stay for a bit, so please feel free to stay and chat with them. And thank you all so much for coming tonight.